with all the difficulties here I'm informed that the name of King Edward VIII is changed, but to me it's still King Edward.
I'm very proud of that.
What was it planned for?
Well, it was planned for a medical school, but with a different curriculum. And I went there. So it's an institution that I thank my God for given me the strength, the courage to be.
But we'll come to that.
It was a very difficult speciality because it wasn't really established at that point.
I'm going to come to you now, Minister. You've worked as a medical superintendent, so you are a medical doctor. You've worked in a hospital, and that was your experience back then. Let's come to now. We hear only of the challenges. We only hear of the good when we speak to people who are in the profession, who are doing the work. But what we see in the news is reports of poor patient care, lack of resources. There was a student, I was actually thinking about it as I was driving now, she studied at another university, and she posted, I think this is her second year actually as a qualified doctor, and she's working, she said it's hard to practice the medicine that I studied because I don't have what I need in order to do it. What is the real status? What is really on the ground? What is really happening? Is what we hear really a true reflection?
Well, I would say it's a mixed bag. As you said in your introduction, that on the one hand, there is definitely huge challenges. And those challenges, one could look at them to say they are objective factors, but they are also subjective factors. But also in that mixed bag, there's also huge areas of excellence, which unfortunately those don't get much of exposure. And maybe just to deviate slightly, just to give an example, and we're talking with some of the colleagues yesterday. Just yesterday, I was just briefing Prof here. There's we now have a medical school in Limpopo as part of the University of Limpopo. They have had 2 cohorts of graduation of MBCHP already. Now, I was reporting to him because we started that together. When I was the MEC, we had our first outreach from Medunza when he was the head, together with other, I think Sam was also in that area. Also some products of this university, Prof. Marivate, you would remember Prof. Marivate, gynecologist. We had Prof. Mokgokong, the late Prof. Class Mokgokong, in surgery. We had Professor Mudiva, Charles, who was the head of surgery. In that team, together with Prof. Ephraim Mokgokong, they agreed with us from Limpopo to develop an outreach program wherein registrars and students would spend time in our hospitals there, and also students, clinical students, to do some of the teaching, as he was already mentioned, this outreach. So it was, when we initiated that, it had landed on fertile ground with him. He mobilized everybody, we sat in one room. In no time, we agreed, and we had this. Now, as a result of that, it took long. That was 1996. Yesterday, we're initiating the construction of the teaching hospital, the new Polokwane Teaching Hospital, which is going to be built, and the contractors assured us that it will be finished in maximum 3.5 years. Now, so that takes, and very next door to it, there's already a site allocated to build a new medical school in Polokwane for Limpopo. But, in terms of media interest, very, very little. Few radios and this and that, newspapers, but and they said no, but good news don't sell, and that's how the media people explained it, that good stories don't sell newspapers. So a lot of the hard work which you mentioning here, Prof. Naika, Prof. Mokgokong, many others, Prof. Glover, so we know that with all the difficulties here in the I've been informed that the name of King Edward VIII has changed, but to me, it's still King Edward. You go across everywhere, even in the smaller hospitals, even where I practiced, as you said, at some stage as a superintendent. There were really a lot of, very committed people and good achievements they don't get. And it's only when something goes wrong that gets, the front pages. So that's a reality of life. So those challenges are there. Now, in terms of those challenges, as I said, I would say there's objective and there's subjective. On the objective side, one would say that from the history which we have depicted, we have moved over the last 29 years from inequality which was based on race, where you would have your Joburg Gen for whites, Bara for blacks, and coronation for black children, and so on. Over time, as we integrated, but we have now moved into a situation where there's a lot of class kind of inequity and inequality as to what services you can access. It's more in terms of your income and a more growth, a differentiation between public and private, with much more resources into the more private health sector. So that is a thing which, amongst others, I know it's a very hot topic about the NHI, which is what we're trying to address in terms of closing that gap. So there, and of course, as in terms of the distribution of resources, you have your huge workload, and unfortunately, in terms of other socio-economic, what you call social determinants of health, a lot of pressure, social issues. South Africa has not resolved a lot of social issues. We have huge amount of violence. You go to all our major hospitals, when you go to the accident and emergency, it will be huge numbers of car accidents, but over and above, more depressing, person-to-person, violence, huge. Come to any of our casualty departments on Fridays and weekends. They will be swamped with casualties, gunshots. In our time, I remember when I was did my internship in Edendale. Edendale was known to be a specialist in stab heart because the people of Maritzburg, they know where the heart is. So when there's a quarrel in the Shebeen, and they tell you that, no, they tell you, so Kwanza Inhliziyo, because they know where Inhliziyo is.
But,
and so the people there, the registrars and all that, they became experts in closing the heart, even as just medical officers. So I'm just giving you the pressure is also in terms of socioeconomic factors, but also resources with allocation of funds not being adequate. Mm-hmm. But there's also subjective factors. The subjective is more about just good leadership. And we see it in many places that sometimes even without a change in the amount of resources allocated, just organizing, making sure that services are properly organized makes a lot of difference. So it's both factors. The softer ones are more difficult, the subjective, which is the leadership. We try to attend it in terms of making sure that the selection of managers, CEOs, clinical managers, we try to encourage our colleagues in different provinces that let's be really more selective in terms of the people who lead, because that makes a lot of difference. Of course, the harder issues is more in terms of the distribution of resources. But if you sort out just the quality of management, it makes a lot of difference in terms of improving the services.
Of course, we're going to talk about the NHI bill in a little while. But it's interesting what you raise about how much violence is seen in hospitals in terms of the patients who come in. That's one of the things. COVID, we all want to leave that back there where it was, but that was one of the things that doctors were commenting about during COVID, where they were saying, thank goodness people do not have access to alcohol anymore, during that period, because they were taking photos in the hospital and doing a compare and contrast during pre-COVID, when alcohol was allowed, and during COVID, when there was no alcohol. And so that, that testifies to what you were saying right now, that a great portion is, in as much as it's medical, but it's also the picture of what our society looks like, that violence manifests into other aspects of what we have to deal with as a country. Prof. Mokgokong, you've practiced medicine. You've taught at numerous institutions. You've held academic positions. You still run outreaches. Which has been your favorite over all this time? You've trained nurses. There are people that you'll point at and you'll say, "Phuma ngaphansi kwesandla sami lo."
It's difficult to compare one's era. There are things I did when I was volcanically fit
Volcanically.
and things that I do now. Just as a matter of teaching, I've always loved teaching and I enjoy teaching here. But I think the biggest challenge of all of them was going to open Medunsa and make it survive. That I always thank my God, gave me foresight, gave me strength, gave me some abilities that I keep sometimes asking, where did I get it from? Because many people from this alma mater of mine believed it was the wrong thing to do.
Why?
When I left. Oh,
Well, I can attest to that.
Really?
I was one of the activists.
You see, and well, I just tell you, I mean, I still remember I had a very young helper secretary then, a French girl, Michelle. When the radio announced in 1977, I think it was about June 1977, that a new medical school is opening. And they had the right, I suppose, maybe even the cheek, to say Professor Mokgokong is going to be one of the teachers at that medical school. Few minutes later, the whole SRC and its following were in my office. And I still remember that very well. And they said they heard from the radio that I was going to this new apartheid medical school. And they said they wanted to know whether it's true. My answer was then to them, the radio would have taken a chance if it wasn't true. They could be sued. So the fact that they announced it's true. My son was part of the SRC, by the way. And they said, now we want you. And I was also at the same time, by the first dean of students of this medical school. It's historic. It was me. All this, the first dean, a person appointed as dean of students was myself here. And they said they want me to leave the deanship. So one of the things I said, I asked the secretary to give them tea and coffee to cool them up. And I told them that the SABC would not have put this on the news if it wasn't true. It is true. And that I'm dean not because I was appointed by students, but the university appointed me. And that first deanship, let me tell you, had no added salary. It was just an added duty. So I said, it's an added duty the university has seen right for me to do. If you are not happy about it, go to the university. I'll also help you. I'll also go to university and say, students don't want me to be their dean. Now, the importance of that medical school started there. And let me tell you that for me to take that decision, I had spoken to many important people, academically and politically involved. And they gave the ultimate answer that we want that medical school, which the whites were going to put it up, whether we want it. We want it to grow. You must go and see to it that it grows. So the message was really to have a school that must be at the level of other medical schools. And that was important. And that's, if there's anything, I always look back to that medical school. And the things I did when I got there in the early days, and the fact that it really started its early days on par with the other medical school, with the same curriculum and everything. It wasn't planned for that, but when it started teaching our children the curriculum was at par with others.
What
And
was
I'm
it
very
planned?
proud of that.
What was it planned for?
Well, it was planned for a medical school, but with a different curriculum. And I went there and I said, I come from Natal University. This is the curriculum. Wits agrees with this curriculum. Cape Town agrees with this curriculum. This is the curriculum we're going to follow. And I used to be a real nuisance in the Senate of that one man. I used to cause complete standstill to make sure that that curriculum was changed. And I had junior, which was young postgraduates who were working there, who had started. Their help for me was very large. We used to have meetings after these things, and I used to have discussions with these young fellows. And they wanted quality. And I said, I'll fight for the quality. And I think this is about it. So if you want to think of the things I've done great things when I was here in Natal. I can enumerate them, but I think we don't want to spend the whole night hearing what I've done. But the medical school of Southern Africa was the greatest contribution I think I did in my lifetime.
Again, I'm going to ask the obvious.
Okay?
What was the intention of a different in parentheses, I'll say subpar curriculum? And what was going to be done with these doctors that were not really up to standard as doctors? What was this plan?
May I give you history? Please. You know, before they decided on having Natal Medical School, they used to call a clinical something degree which Forte produced, and these people were to work like doctor aides. That's what they trained. It didn't work. So starting as a difference, the black man had always to have a lower everything. By our color, we were accepted by white people to be inferior. I don't think it's died completely even today. It takes long. God's worst animal he created is the human species. I mean, things like racism are bad. And everyone knows it's bad, but we keep practicing it. And that's the thing. They wanted to produce doctors, but at a par below white doctors were trained.
Just an academic suppression,
Yes,
and a
that's
professional
what
suppression.
it was. And we were not going to have it. And if I'd allowed it, I would have joined those who said I was a sellout then.
Kudos to you, Professor
So I
Mokgokong.
didn't allow it.
Kudos to you. Kudos to you. Because when you think about it, you changed the trajectory of history with that decision. You changed the trajectory of people's careers with that decision. People who couldn't go to these other medical schools, who couldn't come to Natal and went to Medunsa, would have been in a completely different position, that even with the change of political regimes, that wouldn't have been erased. So till this day, doctors, the current HOD of the Department of Health in KwaZulu-Natal, Dr. Sandile Shabalala, he is from Medunsa. So now, and he was the CEO of Prince Mshiyeni. So that career trajectory was influenced by your bravery and your standing up, despite the SRC coming to your office. So kudos to you for that.
Well, when I retired, by intake and production of doctors, the Medical University of Southern was the biggest medical school in this country. I don't know if it's still the situation, but go further. The first 4 black female gynecologists were not produced by Wits, were not produced by Cape Town, were produced by the Medical School of Southern Africa. So it's an institution that I thank my God every day to have given me the strength, the courage to be involved in. And my son followed me up.
Professor Naika, You've mentored many students in your time. One of your students is Dr. Nolubabalo Unati Ngebelele. Now, she was awarded a PhD in nephrology in 2018, and she was the first Black woman to earn a PhD in internal medicine at WITS. And she credits you for this achievement. And she says in an article, or rather this article says, Dr. Ngebelele is grateful for the support and encouragement from her mentor, Emeritus Professor Sarala Devi Naika in the School of Clinical Medicine, under whose guidance and support she realized the importance of mentorship. From her own experience and recognizing the value of mentorship, she is a host mentor for the International Society of Nephrology's Fellowship Program, whose goal is to provide relevant nephrology training to specialist physicians from countries in the global south. She has mentored doctors from Uganda, Mozambique, and Nigeria, and who successfully completed their studies and have become fellows of the International Society of Nephrology. Now, you come from an entire different era, where you were just describing now that even the idea of a woman being educated was a subject of some concern. Let's talk about the role of and the importance of mentorship in the medical profession and specifically for women.
I think mentorship is key, and going through life, one needs different mentors for different aspects of your life. For instance, I've had wonderful mentors myself in the clinical arena, and then I had one of the most amazing scientists who was my mentor in research at UKZN, Professor Kanti Bula, who came from the University of Bristol on a contract in the Department of Pharmacology. And I was looking for someone to help me with my PhD. And we just happened to meet in a medicine meeting, and that was amazing. So one of the ways that I found that mentorship was important is that you've got to walk the talk. People need to see what you are doing so that they know that this is what they want to do. So, for instance, I've been at international conferences, and then young women come to me afterwards. It's so wonderful to see you amongst all these male professors who are all much taller, speak louder than I do. But here you are, speaking on an international forum. So it actually inspires them, gives them courage that it's possible. Because I think women tend to underestimate themselves. They don't think they can do the same things that men can do for whatever reason. So I think it helps when you can be a role model yourself and other women can be role models for women. And women, of course, besides that intellectual challenge, also have other challenges of family, children, whatnot. So you need a whole lot of support from your family, from your teachers who can understand. As our dean said, you can't shout at somebody who hasn't prepared something to the nth degree. You've got to think, well, there must be a reason for it. Give them a chance to do it. So I've been very fortunate that one of the things when I went to WITS to do was to try and stimulate my research career. I remember when you chatted to me on the phone, you asked me the same question that you've just asked Professor Mokgokong. What do you enjoy most? And I had difficulty answering because I said, I enjoyed everything. At heart, I'm a doctor. That's why I went to medical school. I want to look after patients to the best of my ability. And one of the things I've always said to my students, my younger staff, that remember, this person you are treating is somebody's beloved relative, their sibling, their father, their child. So at all times, do the best you can for them. And if there's any comeback for anything, I'll be there. I have your back. But the day you're negligent, don't count on me. So that was my motto, for how to look after people. Then I loved teaching, and I think it was very good at UKZN as a young specialist or even as a young registrar. Without any training to teach, you got thrown in to teach. So you taught medical students, you taught nurses, you taught allied health specialists, and it was just a progression from that to teach at postgraduate level. But I found one of the things, I think I was so busy treating patients, teaching, that I really didn't have much of an opportunity to develop my research area, and therefore I was so grateful to meet Professor Kantibula, who helped me. Though I must say, one of the things was very embarrassing in that he had a meeting every week for 1 hour on a Friday, 8 to 9, to see how we're progressing with our PhD projects. So whenever it came to me, I had my head down, and I'd say, I'm so sorry, I was too busy. I didn't have a chance to do anything. So after you've said that twice or thrice, you realize this is no way to make progress with your PhD. So I'd take some vacation leave, go and spend time in the lab, or do whatever I needed to do to progress my project. And so then I learned how to do a PhD and how to maintain a PhD from Professor Bula. And subsequently, with his mentorship, I learned how to be a mentor for research students, how to encourage students. And therefore, like people like Dr. Unati, Professor Nomandla, I've had the pleasure of supervising them through masters and PhDs. And the important thing, I think, is for people to be persistent, to work hard, and not to lose sight of the goal. And one of the other areas that I realized how important this was is also one of my roles in the International Society of Nephrology, which was totally voluntary. I was appointed as chair of the Africa Regional Committee. And I must say, if nephrology at that stage was sad in South Africa, it was desperate in other countries. And the first countries we went to were Ghana and Nigeria. And Nigeria is the most populous country in Africa. And it was desperate just to see people not getting any nephrology care. And in those 6 years when I was chair of this regional committee, it was a very exciting time in that we went to different countries in sub-Saharan Africa. There were very few specialists, so very few nephrologists. So we met deans of medical school, heads of medicine, ministers of health to talk about nephrology. And the first thing we went to say as the International Society of Nephrology, we're not here to tell you to dialyze everybody, but we're here to tell you that nephrology education is very important because a nephrologist is a well-rounded physician because kidney disease is set in the context of the whole body functioning well. You have a pneumonia, you can be in kidney failure. You have a heart problem, you can end up with a kidney failure. You have cancer, you can have kidney failure. So therefore, you need to be a complete, well-rounded physician to be able to look after people properly. And you know, it was interesting that we were able to give this message. And then I found there was an avalanche of people wanting to train with me from sub-Saharan Africa to come to Wits to train in nephrology, some of them in internal medicine, but largely in nephrology. And in fact, a lot of my PhDs were these international students from elsewhere. And in fact, I think I've trained more doctoral students from sub-Saharan Africa from Wits itself. So I think that was a very exciting time, learning about how to do research and then teaching other people to do research.
Minister.
Elephant in the room.
Elephant in the room. And Professor Glover said we must be opportunistic. The NHI bill has been passed. Just today, there was somebody on the radio, on one of the radio stations, and they were talking about it this morning, and they were talking about, you know, performance in hospitals, and one of the callers was phoned in and said, you know, we need more hospitals. Healthcare is a big subject. Second to, well, if not on the same level as education in terms of, you know, how people feel about it and how they feel government is delivering on that. Right. So the NHI bill has been passed, and this is how it's been reported in the media. South Africa's National Assembly approved a new law that will pave the way for the introduction of universal health insurance. A plan, its critics argue, will be financially unsustainable and impossible to implement effectively. And the reason they say it will be impossible to implement is because they say they don't trust government to implement it correctly. The National Health Insurance Bill aims to ensure that all South Africans have access to quality healthcare services, that word again, quality, and provides for the establishment of a fund that will be used to pay for almost all medical treatment from accredited providers, with rates to be determined by the state. Now, I asked this question on a personal level. Until 7 years ago, I only used public health care. I'm a huge advocate for clinics, for everything. And this is what changed it for me. I went to my gynecologist, and he prescribed something. And he said, I never want to see you again for this medicine. Next time, go to the clinic, because I'm charging you a consultation fee, and and you're going to pay for this medicine. And again, when I had my daughter, the pediatrician I went to said, this is the last, for the 6 weeks checkup, he said, this is the last time I want to see you. Next time, he said, pack a lunch and go to the clinic, because what you are getting from me, I'm charging you for it, but the clinic will not charge you for the exact same thing. All you need, the only price you need to pay is patience, right? So I have good testimony about the medical health. My grandmother was treated at Inkosi Albert Lutuli. She went for her chemotherapy there. She went to Addington. So I know the positive side of healthcare. But the majority of South Africans speak a different language. And the result of that is when the NHI bill is discussed, it's discussed in that context. And then people say, but these people have let us down. These people have let us down. The previous regime even did a better job. And those things sting a little bit. So here's the opportunistic part. Please tell us, what is going to happen? What is the good? What is the plan? Can it be done? Can we trust?
Well, indeed, it can be done, and it must be done, because the alternative of going on the trajectory where we are, I mean, I touched on it a little bit earlier on to say the problem in terms of where the South African health system is currently is that while we moved from a situation where access and quality of care would be determined in terms of race in the previous era. Now, when it comes to the, progressively, while we opened up in terms of no more the Joburg Jan for the whites, Bara for the blacks, King Edward for blacks, Addington for whites, RK Khan for Indians, and all that, we stopped all that and made sure that people could access in the public health sector. But at the same time, by also opening up, maybe for good reasons in that, in terms of our constitution, we also, had to say that people can be able to develop in whatever, even in terms of trade. And I mean, I'm sure both Prof. E.T. and Sam, as being people who have been in the practice, I mean, when we were students here, I mean, if you were to check how many private hospitals were in Durban in the late 70s, you would count in one hand, not even feel your fingers in one hand. But over the time, as democracy opened up, we also gave a proliferation in terms of, in a very, uncoordinated way. And what that has done, it's taken in terms of not just financial inequality and access resources, in terms of what the kind of cost which your specialist was telling you, the kind of spiraling costs which those who have income then spend, even the middle class, even people in the middle class where we are today, many are really, drowning in terms of the cost. They're demanding, whenever, just in the last public service strike, one of the demands was higher subsidy by the state for the medical scheme, because tariffs are rising every year. So that part it's unsustainable. But on the other hand, as I've said, the public health sector, which is opened up, people can access a whole range of free services, even except for mothers and children under 6 who have absolutely free service. Primary health care overall is free for everybody. At hospital level, there is a means test, but generally most people access the services free of charge. So that puts a lot of strain. But as I've said, there's a lot which can be done even in terms of improving, notwithstanding. So what we are saying is that, I mean, if you look at just the training, it's very costly to train even an undergraduate medical professional, even more in terms of a specialist. But because of the manner in which this unequal and not properly regulated system on the proliferation on the private side, you find that those very highly subsidized graduates and postgraduates, after they've qualified, it's very difficult to keep them in the public health, which has invested, the public which have invested, and also not only in terms of the cost of training, also in terms of whatever learning you do. You don't learn this in private hospitals. I'm sure none of the colleagues here who are all the specialists, they will tell you that I did this at Netcare Hospital. No, it's King Edward, it's Addington, it's all the public health with public health patients. So what we are saying is what we need to do is to make sure that there is a better equilibrium in terms of the allocation of the resources, because we have a situation where now the people who are at the lower income are stuck in terms of the poorly resourced and highly burdened public health, whereas in total as a country, in terms of what we spend on health, it's far above countries, even high-income countries. When you take together what me and you who have some kind of medical insurance put together in terms of what you spend on average on an annual basis. In terms of GDP, the average.
To ignore all the taunts and everything that they made to you. Do you think you were right? Because Medunsa has now produced more doctors.
Open a medical school. And I believe the political setup could never have stopped it. So it was going to happen. It was weather. And Natal answered, sent me a telegram, and I hid it from my elder brother who was really...
Previously on SA Health Icon.